Today we're going to talk about what do I need to do as a physicist when I am, second checking a 3D CRT plan. And we will start, of course, with a poll question. So here's a question. I just bought the latest, state-of-the-art planning system. It has been commissioned thoroughly, and we do regular QA testing on the planning system. And the question is, do I still need to do MU verification per plan? I still need to do MU verification per plan, or I need to do it once a month, or maybe I do it once a year, or there is no need to do MU verification. Planning system has been commissioned, QA'd, it goes through monthly, annual, rigorous checks. So what do I need to do here? All right, Tim, I think once we hit around 80% participation on the response, we can close it down. And I see, we have responses going 3 different directions. There's 71% people choosing answer A, about 1/5 choosing answer B, and we have a little less than 10% choosing answer C. Looks like everyone is agreeing we need to do some type of verification because no one so far is choosing number D. We are at 57%, so maybe we can close it. I'm going to close the poll.
Yeah, I can close the poll.
Yes, please, go ahead. All right. And we can show the results, right? They can see the results.
I think it worked, yeah.
All right. So it looks like the majority have chosen answer A, with some answers between B and C, and no one answered D. So it's good to understand that, yes, we still need to do some MU verification. And the question is, what is the frequency of this? All right, and we're showing the results, and I want to close this. The answer is it has to be per plan. Every plan is different. Every plan has different parameters and complexities associated with it. And you really have to verify and confirm the output of the planning system for every single patient. And this, this mentality will also come with us when we transition to IMRT. You have to check every plan. You have to do a quality assurance check on every plan that you generate. Even if your treatment planning system is rigid, it has regular quality assurance, you do your monthly, your annual, etc., but you still have to check every plan. All right, so now this is what today's lecture is all about. We will start with what do I need, what's the data I need to do monitor unit calculation verification, and then in general, how do I put that into a second check plan? Okay, and those are the 2 references I'm using heavily, and they are available for free from the AAPM website. You can go and, aapm.org, and you go to the publication and you will find them over there. So planning system has done its job, right? We have a plan. And then it comes to the second physicist or to the other physicist to do a check on the plan. So what are we looking for? And how do we start doing that? A quick recap of what we've talked about so far, like from the beginning of the course. Of course, you have to do your TPS commissioning, right? And then you have to train the staff. And this is what we are doing here. We are training people. It could be initial training for some. It could be continuous education training for others, but it's also part of training, what we call professional development. And you also have to have your clinical protocols. Now, once you're done, then you want to think, okay, now I need to put in the physics protocols. How do I do plan verification? How do I verify the monitor units? And reminding you with the first lecture that you had with me, we were talking about ICRU recommendation and the point that we need to choose for the planning prescription and normalization. So that point that you have chosen for your plan, that is the point that I will use when I'm doing the monitor unit verification, right? So it's going to be that particular point, whether that point was your isocenter or whether that point was in the middle of the tumor. So now we are putting together the point that I chose consciously for the planning. It's going to be the same point I will use for the monitor unit verification. Okay, it's not. Wait. All right. And this is a bird's eye view. So this is a general view of what we're looking for. The physics second checker, the physicist who's checking the plan, you're also, you're looking at isodose coverage, you're looking at DVHs, you're looking at beam angles, energies to use. Do they make sense? Do I need to use bolus, not bolus? So basically you're checking everything in the plan that was already done. You want to make sure that the planner did not forget or, or missed a point from the prescription. Maybe the physician asked for bolus, the planner forgot to use bolus, etc. And overall, does it make sense? And if there are any couch angles that you're using, you want to also make sure that there's no collision. You're not hitting the patient or the gantry is not hitting the couch, etc. So this is something that we all, know how to do. Basically, you're kind of redoing the planning again, but this is from a second physicist, going through all the planning parameters. Now, this is important. And this is where we're going to focus on. This is the monitor unit verification. The plan could be perfect in terms of geometry, setup, and what you see on the screen. However, in order to deliver that plan, the linear accelerator only knows one thing, monitor unit. That's your beam on time. And if that was not correct for whatever reason, the plan will not be delivered properly. So that's what we're looking at. After you verify the plan technicalities, now you want to go to the output. And depending on your vendor, whether you have, I don't want to mention any names, but some vendors require that you also export the plan to the record and verification system. So the second checker not only wants to verify that the monitor units are correct, but also that the plan has been exported properly. And so the linear accelerator can execute that plan. All right. Okay, so I've given this lecture to different people in different countries, and usually I hear different answers when I ask, do you do monitor unit calculation separately? I've heard yes, and I've heard no, so and that both are honest answers. And I've also heard, no, yeah, we think we do. So, and by the way, you do not have to buy an expensive third-party software. If you can buy it, that's good. That's perfect, which means that, it's easier for you. If you don't have the money or you're just starting, you don't have the budget for it, the physics team can build a monitor unit calculation sheet using Excel. And in fact, the first 7 years when I started practicing medical physics in my country, we had an Excel sheet that we kept, and that was our basically second check. That was our, MU verification. And it's not too difficult to build an Excel sheet. So right now, I'm going to go through simple, overview of what we need to do an MU calculation check. And you can, if you're comfortable using Excel, please go ahead and use that. If you're not, you like MATLAB, or, you could do Python programming, you can also use the same principles. If you have a software, a third-party software that you're using for MU check, you still need to make sure that that software is doing a good job. So you still have to do some manual calculation in the beginning to compare your results with the software result before you employ it clinically. So now, going into this, what is the first data point that I need to know? Well, that is your reference geometry, or what we like to call your linear calibration geometry. And this is basically the only point that we have that has an absolute number. So I'm using here as an example, I'm using 100 cm SSD. So my SSD here is 100 cm. I'm using depth of D max again as an example. And for a field size of 10 by 10, I will calibrate my linear accelerator to give an output of 1 monitor unit, 1 centigrade per monitor unit, meaning every 1 MU, I should measure 1 centigrade. It's a 1-to-1 calibration. Other people do their LINAC calibration differently. It does not matter. As long as you know your output of the LINAC in terms of centigrade per monitor unit, and what are the parameters needed. For kind of, simplicity, I will use this setup, 100 cm SSD, depth of D max, and field size is always 10 by 10, by the way. And I'll use that kind of to build on my equation later on. Now, there is something that we will need, something that you see maybe in Faiz Khan book, Physics of Radiation Therapy, or maybe in the IAEA book or reports. It's called source calibration distance. So this is directly taking the distance from the source all the way to your point of calibration. In our example, this would be 100 cm, which is the SSD, plus Dmax, right? It could be just 100 if your LINAC is calibrated using isocentric technique. This would be simply 100. So we need to know this. So this is where we're starting. How is my LINAC calibrated? And we know that point. So here's a question. This is a very easy question. We are treating a spine patient, single beam, 10 by 10, open geometry, so there are no wedges, no blocks, nothing. 100 cm SSD to a depth of 1.5 cm. And we want to give 800 centigrade. What is the monitor unit? So the first thing we notice is that treatment geometry is exactly equal to the reference or calibration geometry, right? We have the 10 by 10 single beam. It is open, 100 cm SSD, and the depth is 1.5 cm. And 1.5 cm is the maximum for 6 MV. So in this case, remember, under those geometries, 1 centigrade, 1 monitor unit. So under those geometries, then the monitor unit is equal to dose divided by the output factor. So 800 divided by 1 is 800 monitor unit. And now let's, shake it up a little bit. What if the field size is different than 10 by 10? And here's a question. How often do you treat with 10 by 10? You do sometimes, but not very often. Usually you treat with rectangular beams. So in a clinical setup, if you were using a different beam or a different field size other than 10 by 10, then we need to have some sort of a correction factor for 10 by 10. And that correction factor is what we call the total scatter factor, SCP. This is how Faiz Khan book refer to it. In the IAEA report, they call it relative output factor, ROF. Now, whatever you call it, as long as you realize that you need some sort of correction to take the field size back to 10 by 10. So what we're doing here, we're taking the clinical field size back to the reference field size, 10 by 10. And basically, the physicist measures this during commissioning. And it's dose at field size divided by dose at 10 by 10 at the reference geometry that you have for your LINAC. So what is this doing? This is taking back the field size to its calibration field size. So now let's spice it up a little bit. Same patient, we're treating spine, we're giving 800 centigrade, but now this time we use a rectangular field size, still open, still 100 cm SSD, and still a depth of Dmax. So how do we go about this? All right, what we notice is that treatment geometry is the same as the calibration geometry, except for the field size. And to correct for the field size, we have to do two things, unfortunately, because we do not measure rectangular field sizes. During commissioning, we only measure square. 4 by 4, 6 by 6, 8 by 8, 10 by 10, all the way to 40 by 40. So we have to do a little bit of math to get what we call equivalent square field. And that's, everyone knows this. I don't want to go into how to do that. Khan and the IAEA book explain it perfectly. But now we were able to find an equivalent square. In this case, it's 8 by 8. And this is how the monitor unit equation becomes. Right, and by the way, everything that we are going to use, all the corrections we're going to use will be in the denominator of down here. Why? Because we are correcting everything back to the calibration geometry. K0, this number, is only true for 10 by 10 field size, 100 cm SSD, and depth of D max in our example, right? So anything that is not 10 by 10, open, Dmax, 100 cm SSD, we have to take it back to that. So we have to do all these corrections. So here's a question, a second question of the day. Let's say our patient, I'm treating spine field, for example, 6 by 12, but now I'm using a block. I'm blocking or I'm shielding 10% of this field. And the block looks like how you see it here. So a little bit on the corner, upper, a little bit on the corner, lower. So now the question is, does the monitor unit stays the same? The collimator setting, the field size is 6 by 12, so nothing changes. Do we multiply the output factor by 10%? Like reduce it by 10% because I have 10% blocking. Or do I find a new equivalent square field size and find the output factor? Or I need to separate collimator and phantom scatter. What do you think will happen? And by the way, there is the textbook correct answer, and there is the practical answer that we used in our clinic back in my home country. It is not 100% correct, but it will give you a closer answer. In this lecture, I will only be giving you the textbook correct answer, but maybe you can reach out later to practically speaking what we can do. So what we are seeing here, Tim, so we have people choosing different, the A, B, C, D, we have different answers, different everything. 50 per, I don't want to say 50%. Let's see, let's wait until we have at least 50% participation.
Yeah. And then
So think about it. Yes.
Right after this, after we talk about this question, there were a couple comments in the chat that we can go back to some of your earlier comments and just reemphasize.
I know this is technical. This is a technically heavy lecture, so I'll try to go in a slow pace, but we also want to be mindful of the time. If any questions we don't get or comments we don't get to answer during this lecture, can you please just write them down, send me the email, and then I can answer all of them.
Yes, I will copy all the questions.
I appreciate that. Thank you.
Email. Yep.
All right, so what we see here is that we have answers across the board, A, B, C, D, with more than half choosing C. And we'll keep that in mind. However, the textbook correct answer is D. This is textbook correct answer. So we have now two types of scatter. We have collimator scatter, the scatter coming from the machine, and that is identified by your field size, 6 by 12. So the collimators have opened to 6 by 12. So you have this scatter coming from the machine. And then we have a smaller field size, right? We have introduced a little bit of shielding. So what's going inside the patient is a smaller field size and identified by, whatever the scatter that remains after we remove the blocks. And that is what we call the phantom scatter. So in fact, we will have two different field sizes, the collimator scatter field size, and then a smaller, field size that goes with the phantom scatter. All right, I have one more question to ask, and then we will go to the comments.
Okay, sounds good.
So question number 3. All right. Basically, all the linear accelerators we buy today have MLCs. Some clinics still do choose to have cerebin blocks. For electrons, of course, you still need cerebin blocks. Does your answer change if I use MLCs to do the blocking, or if I use cerebin blocks? Right, so the shape of the block is the same. And let's say 10%, we're blocking 10% with this particular shape. Does it make a difference now if I use MLCs versus cerebin block? What do you guys think? All right, it's good to see that people realize that there should be some differences. Okay, or maybe. And then we have clear winner here. If block is okay.
You want me to end the poll?
Yeah, let's end the poll. So the majority has chosen answer C, and this is correct. Wait. Whoops, sorry. Oh, no, this is wrong. Hold on. If blocking is done with MLC, nope. This is actually wrong. Hold on. I need to stop this. So the correct answer, so when I put the number, when I put the questions, I forgot to change this. The correct answer is answer number C. Let me just do this. So this is the correct answer. So remember what we said. We said that, you know, we need to separate phantom scatter from collimator scatter, right? Let me do this. Hold on, and then I'll come back to the answer again. I'll do a quick change. Okay. So we have separated phantom scatter from collimator scatter because we have a blocking. And the question is, do we need to do anything additional after this if we have MLC? Now, if we have MLC, the only thing we need to do is just separate the blocks. I mean, separate phantom scatter from collimator scatter. MLC transmission does not factor into the monitor unit calculation at this point. MLC transmission will factor in, you know, in the area underneath the blocked area. So you'll get, you know, if I'm looking at the dose cover underneath the block with the MLC, I'll see a little bit more dose. It will not change, however, the monitor unit you calculate. On the other hand, a cerebin block requires a tray. So I will be adding a tray, right? And then that tray is going to attenuate a little bit of the beam. Now remember, the output factor of your linear accelerator was done with open beam. You have 10 by 10 field size, you have, in our example, 100 cm SSD, and then D max, and it's an open beam. Now I have introduced a tray over which the block is sitting. And so if I am doing a monitor unit calculation with a cerebin block, yes, I need to separate phantom scatter from collimator scatter. And also I need to add a tray factor. The tray factor is basically, what is it doing? It's taking this variation, which is I have a tray, I have a plastic tray introduced in the path of the beam, but the calibration was done with open beam. If I'm using MLCs, the monitor unit only separates collimator from phantom scatter, and that said, there is no tray, there is nothing, you know, MLCs are part of the machine. Transmission of the MLC will affect the doses that are in the tissue hiding here, right? But they will not affect your monitor unit calculation. Tim, I can stop now and take a few questions.
Yeah, I think I just have one question. I'm going to combine a couple of the comments. So when we do commissioning, we take a lot of measurements under fixed geometry, and that gives us fixed beam parameters like our wedge factors and our PDDs, and we put those into the TPS. Can you expand on or clarify why we need to use a secondary or independent MU check if we're putting all of that data into a TPS?
Yes, that is actually the core of this lecture. What you are putting in the computer is in your TPS is your fixed geometry. square fields. You are putting your PDDs measured at, certain distances with a flat water phantom. It's all homogeneous. So first of all, you need to do your TPS commissioning, and you have to do that thoroughly, right? You have to verify under different geometries, different modifiers, tissue heterogeneity. You have to verify that what your TPS is calculating is equal to what you measure in your phantom, in your heterogeneous phantom. And you can get recommendations from both AAPM or the IAEA. But you cannot account for every single variation that comes with patient treatment. Patient treatment have weird blocking shapes, right? You could have a block that is very weird and only a small area left for treatment. You can have patients, rolled on their back or sideways, having scars, having different tissue irregularities. You can also have wrong data point in the planning system that for whatever reason, you did not test for it because you're only doing standard geometry. You're doing 5 by 5, 10 by 10, 20 by 20 during your, monthly or annual quality assurance. So you could have some wrong information or wrong calculation that will only appear under certain complex geometry when we treat patients, right? And so the two reasons is that what you check for, what you enter in the planning system is ideal square geometries measured in water. Patient treatment is everything but. Patient treatment is non-homogeneous, a very complex geometry, complex shielding, and you have also complex body irregularities, etc. The tissue, the valleys, I mean, head and neck by itself, if you treat head and neck by itself, don't tell me this is equivalent to measuring 10 by 10 in water. The other thing is that you could have actual computer bugs or problems that do not show up in the simple geometry that you measure and QA from the TPS, and they will only appear under those, regular, very complex treatments we have for the patients. And then there is a computer scientists use this acronym, GIGO, garbage in, garbage out. A computer will always give you numbers, but are they the correct numbers for this patient? It could be that any particular geometry will reveal a bug in the computer that you don't test for because you only use simple ones, 10 by 10, Dmax, or depth of 10 cm, and that's it, right? So that's why the recommendation is also do not treat without verifying every plan is correct in terms of output. And this, you'll take it with you as you also transition to IMRT. And IMRT, things become more complex. So with 3D, I can simply do an Excel sheet, calculate the monitoring unit, and say, that's good, let's treat. For IMRT, now you have to spend more time to measure. And if you're doing stereotactic radiosurgery, SRS or SBRT, then you have to be, again, more careful because the amount of radiation we're giving is too high. So that's why we have to do it per patient or per plan. But it's a question that a lot of people ask. And it only takes one time for the computer to give you a wrong outcome that leads to, la samahallah, leads to, bad things for the patient that your clinic cannot recover from. You don't want to be responsible for someone's demise because you did not verify the computer output. And there was a very famous case in New York in 2007 where a patient ended up getting 3 or 4 times the dose on their cervical spine, on their neck up here. They became quadriplegic and they were dead within the year. Within 9 months or 10 months, they died. And that was the reason. There was a computer bug, and the physicists didn't do their QA in time. They waited until, I think, the 3rd fraction. And for that particular patient, the computer bug, the computer problem, resulted in 3 to 4 times the dose to the cervical spine. So you don't want to be in that situation. It's always good practice, and it's highly recommended you check every plan you produce. Any other questions, Tim? That was a really good question. Any other questions we can?
I think for now we can continue with the presentation and we can come back to anything else
Perfect.
that's come up already at the end.
Okay, so, you know, again, going forward, and this is just a generic reminder. So, you know, if it's too simple, I apologize, but it's good to remind ourselves of what does it take. And so if you're building your MU calculation Excel sheet, you know, you can also communicate with me, send emails through RCC, and then I can maybe help you. Or if you're buying a software from a vendor, those are the things that you still need to look for and enter and commission. So now what else do we need? Well, how often do you treat patient at Dmax? How often does the physician prescribe dose at 1.5 cm or 3 cm, you know, the Dmax of different energies? They do sometimes, but most of the time we are prescribing dose to depth, you know, 5 cm, 10 cm, or midline. You know, we were treating whole brain, we prescribe to midline. We're treating tangential breasts, you know, we're prescribing in the middle of the PTV in the breast or to isosender, depending on how you do your breast setup. And so because we have deviated from the way we calibrated our LINAC, and in this example, it's Dmax, then we need some sort of correction factor to take it back to Dmax. And that correction factor is either PDD, percentage depth dose, or TMR, tissue maximum ratio. And both are equally good, and you can use both of them. Most of the time, I have encountered that people are comfortable with using percentage depth dose. So moving forward in our examples, I'll be giving, you know, PDD, but both are equal. The idea here is I need some sort of a correction, right? To take the clinical treatment depth, this is where the patient is being treated, back to the reference depth, which is Dmax, you know, wherever your output factor is defined at. So now let's see how the question become. I have a spine field. I want to give 800 centigrade. I'm using 6x12 single beam, and I'm blocking using the MLC. 100 cm SSD, so the SSD is still 100 cm. But now the depth of spine or depth of treatment is 5 cm. And again, you know, the assumption here, as I said, we will be using PDD tables. So what do we notice? Okay, we notice now we have really quite a difference between treatment geometry and calibration geometry. The field size is different, and there is blocking, and we have depth. And so, as we said, you know, we have to find the equivalent square field size, because again, physicists only measure squares. We don't measure rectangle. So what is the equivalent square? And because we have a block, you know, we have to separate collimator scatter, and collimator scatter is with the big field size. That's your collimator opening. That's your, you know, 6x12 or the equivalent 8x8. And then the block is with the smaller field size. That's a phantom scatter. And then what we're going to use now are the PDD tables at depth of 5 cm for an 8x8 field size. And those are, you know, an easy lookup table if you have an Excel sheet, you know. If field size is 8x8, you know, look at the depth, what is the PDD? And so this is how the equation comes to be. Now remember, everything is always put lower here in the denominator. And the reason is, you know, we put everything down here because everything literally, excuse me, hold on. I lost my pointer. Everything is correcting back the treatment field to the calibration. So physicists, we like simple things. I like 10 by 10, 100 cm SSD, Dmax, open beam. That's it. Don't bother me with anything else, right? But the physicians, they're not using this for treatment. The physicians are using so many different combinations. And so we need to correct for everything, changes in field size, changes in block versus open, changes in depth, so that this can be used now in you know, in our treatment or in our MU calculation. Okay, what about different SSDs? How often do you treat patients at SSD equals 100? Maybe 10% of the time, you know, especially if it was palliative. Most of the time, you're doing, you know, pelvis treatment, prostate box technique, you're doing whole brain, you're doing tangential breasts, maybe you're doing, 3-4 field lung treatment. And so those are different SSDs. And so what happens now is that the entire setup is different than your calibration setup. Again, the physicist is saying my 0.1 centimeter per mu is only correct for these, setups, this geometry. And now we are treating the patient in a different geometry. So we have to correct for that. And in radiation, anytime we move further away or closer to the radiation source, we use the inverse square correction. And the fancy names you have in the IAEA book or in, CON, call it SSD correction or SAD correction. I don't care about the fancy name. We are just basically doing inverse square correction. We want to correct for this difference in distance. So now this is the source and this is the point, but I want to take it back to this distance. So think about it. If at 10 cm away from a radiation source, I get 2 gray. How much dose do I get if I'm at 20 cm away? Right? We do inverse square correction. We do 10 over 20 all squared. And so what we have is the radiation dose will be lower by the ratio squared. Vice versa, if I'm closer to the source, at 10 cm away, I'm getting 2 gray. What is the dose I get if I am closer, 5 cm away? So always use this simple analogy that we all know, that we all grew up learning in physics and radiation physics, to basically figure out how do you want to do the inverse square correction. You will find different terminology, whether in the IAEA report or the Physics of Radiation Therapy, the FISCON book. They have different names. To me, I just call it inverse square correction. So this point is 1 centigrade per mu at this distance. What happens now when the SSD is not 100, the SSD is 200, or the SSD is 90? Then I do inverse square correction, right? So in our example, this would be the correction. If you are using PDD tables, then you will also do inverse square correction for the depth and the Dmax. The fancy name of Maillard F factor is just inverse square correction for the 2 terms. So PDD, dose at depth, a dose at Dmax. And in PDD, those were taken at 100 cm SSD. So if dose is at 10 cm depth, when you did your commissioning, like when the physicists do their commissioning, we're doing PDD tables at depth of 10 cm. The actual distance from the source is 100 cm at depth. All right, so 110. But now I am treating at 120. So now the point is even further away. So 120 is at 10 cm, 130. So you do the ratio. And you also do that for the Dmax, right? So Maillard F factor is just a fancy name for doing inverse square correction for the 2 terms in your PDD. And that's it. Consider them one at a time. Consider this by itself, and then do this by itself, and then put them on top of each other. And this is what we call the Maillard F factor. Now you will see it displaced, you will see different, presentation, 100 plus D divided by, 100 plus D max by themselves, and the SSD plus D, SSD plus D max by themselves. Or you'll see them, the depth and D max separated. It does not matter. This is just a ratio. It's just inverse square correction. So I know when I was still studying, like 25 years ago, when I was still studying medical physics, the Maillard F factor was too difficult for me to remember until someone, actually one of my colleagues, said, but Shada, this is just inverse square correction. Stop memorizing. I'm like, oh, okay, yeah, that makes sense. It looks intuitive, but it wasn't for me as a student. So that's why I always like to mention it in my lectures. It's just inverse square correction for the depth and the Dmax. If you're using tissue maximum ratio tables, you don't worry about correcting for different SSDs. Okay, so now, how does this look like? We want to treat spine patient. 800 centigrade with 6x12 field size. I'm using MLCs for blocking. And now its treatment depth is 5 cm isocentric. So it's SSD 95 and depth of 5 cm. And then your equation, well, basically everything is changed from the reference or calibration geometry the physicist did. And so we have to basically correct for everything. We are correcting the collimator scatter, phantom scatter. So this takes into account the field size and the presence of blocking. We are correcting for the depth. That's your PDD. And then the change in SSD, 95 cm SSD, right? The change in SSD, we have to correct for it in 2 places. The inverse square correction is a direct correction for the output factor. I think in Khan's book, this is called SSD factor, I believe. And then if you are using PDD, then you also correct inverse square correction for the 2 terms of the PDD, and this is called the minor F factor. And then we have other modifiers. Other modifiers, if I have cerebent block with a tray, I have to correct for tray factor, I have to correct for table. If the beam is posterior, right, patient is supine, so patient is sleeping on their back, looking, to the ceiling. But the beam is posterior, is going through the table. So then I have to have a table factor because that attenuates the beam. We have to account for it. If there is a wedge, of course, there's wedge factor. If the prescription point is not the isocenter, I mean, so far we have assumed in our example, because let me go back quickly. Almost there, yeah. So far, we're assuming that we're prescribing to the isocenter, so there is no off-axis issue. There's not a problem here. But if your prescription point is not at the isocenter, which could happen if we're doing tangential breasts or chest wall, it could also happen if I'm doing lung or maybe pelvis, etc. Then I need to have an off-axis ratio. So everything comes here in the lower part in the denominator, because everything is trying to correct back to the geometry where this is true. All right, we have another question. I do my best. I do everything that Shada told me. I do everything that I can find on. And once I finally do the MU calculation, it should be exactly equal to the TPS MU calculation. Yes, no, or depends. All right, and we have different answers here. We have people choosing yes, we have people choosing no. So far, the majority goes with depends. Questions like depends or sometimes or not enough information, sometimes they are correct, right? All right, can you stop the poll?
Sure can.
Thank you. And sharing results. So yeah, the answer is depends. And here's the thing. If your patient is 100% flat, 100% water, and like a big box of water, then it is a good assumption to say manual monitor unit calculation is going to equal TPS calculation. But it's not, unfortunately. And so what are the assumptions? And this is also true for some third-party softwares. Some third-party softwares basically just sell you a fancy, manual calculation, where it takes the data from the planning system and it populates and it gives you a number. Other softwares, they actually have kind of a replanning, so to speak. They also have the CT of the patient and they do another high-level calculation of monitor unit. So again, not necessarily because you have bought a software that, it's always going to give you 100% exactly what the TPS gave you. So what are the assumptions that we are doing when we're doing this manual calculation, whether by hand or by Excel or, Python or whatever you guys use? First of all, we're assuming an infinite water fountain, so perfect scatter conditions. Patient is finite in size, so scatter conditions change. Other assumption, we're assuming flat surface. This is the water tank that I have taken the measurements on. It has a flat surface. Patient has a curved surface. Our assumption again, it's all water. So homogeneous medium, by default, that means we have electronic equilibrium and we have a uniform attenuation all throughout. Your patients, they have different tissue, air, lung, bone, fat, adipose tissue, etc. And between the tissue interfaces between air, air and tissue, air and bone, like in your neck area, or maybe the sinuses, upper neck, lung bone, lung tissue, those tissue interfaces, we have electronic disequilibrium in those regions. We also have different attenuations because of the different tissues. The other thing is that manual calculation then depends on estimation. Yeah, that looks like a 10% blocked area. And then the shapes are very irregular. So even if you try to do textbook scatter analysis, you will end up also trying to kind of estimate or assume certain shapes, right? For the field size factor, we don't take an infinite number of field sizes. We usually do like 3 by 3 for 3D CRT. We have like 3 by 3, 4 by 4, 5 by 5, 8 by 8, 10 by 10, maybe 15 by 15, maybe 20 by 20, 25 by 25, 30, and 40. What if you get an equivalent square field size of 16.7? Then you have to estimate to 17. Well, I don't have 17. The physicist during commissioning didn't take 17 by 17. Do I estimate higher or do I estimate lower? So then you have to do a lot of estimation, or maybe you can do interpolation. You can write an equation and kind of you interpolate, using that equation line. So there's a lot of estimations and interpolations for your field size, and also for your, the field size, by the way, also affects the PDD. Whereas in your CT plan, on your TPS, basically the geometries are taken as is during calculation. All right, so what am I doing here? You just told me I need to verify the TPS monitor unit calculation, and then now you're telling me I'm not going to get the same MU calculation. So going back to the person who asked a question, why are we doing this? Here is the reason. We are not looking to get exact same value of monitor unit. We actually cannot get that, as much as we can with our manual calculation. What we're trying to make sure and verify that there are no computer bugs, there are no mistakes, there are no large discrepancies that will end up to, a patient, getting overdosed, or, or whatever that, other issues with the patient. So we're not looking for an exact number. We're looking to make sure, does it look good? And so in this case, now we're looking into, so what is the allowed differences? What is the allowed, is it 2%? Is it 3%? Is it 5%? Right? So now I'm saying, okay, so what I'm looking for here, what is the discrepancy within which I can say I have good treatment or have good output? And we will use now going forward the report number 114 from the AAPM. Of course, you can use equivalent reports from the IAEA. First of all, when you are doing your monitor unit calculation, are you assuming homogeneous conditions? You're going to assume your patient to be all water, and this can happen if you turn off heterogeneity correction in your TPS. So then we're assuming everything is water. And, you're now comparing output versus manual calculation. So if you're assuming your patient to be homogeneous condition, then we can look into what is the calculation algorithm in your planning system. You know, every planning system have different levels of algorithms. It could be pencil beam. It could be like very old planning system had Clarkson monitor unit calculation for scattering. It could be triple C. It could be triple A. It could be Monte Carlo. So what are you using? So first of all, is your patient all water? Is your patient homogeneous? And what are you using for calculation in your TPS? And now we look at what are we using for manual calculation. If everything is the same, and this will happen only for the TPS commissioning, right? In water phantom, we take data in water phantom, and one of the, initial tests we do also in homogeneous medium when we're commissioning the planning system and we're verifying the output. Measurement done in water phantom, calculation in a nice cube phantom, and the physicist should expect, minimal field shaping. Physicists should expect, 2 to 2.5% discrepancy. Now, once you start introducing patient geometry, right? Patients have complex geometry. What and how are you doing the monitor unit calculation? What I just explained, what I just talked about, and the examples I gave, we were assuming a cube phantom. Even though I was saying, patient is prone, we're treating the spine with this, the MU calculation we did assumed a cube phantom. And so different calculation algorithms or similar, am I using same patient geometry? Or I'm assuming in my own manual calculation a cube phantom approximation, then we could either be around 2% discrepancy or up to 5% discrepancy. Now, 5%, look at this, if we're doing, of course, wedge fields off axis. Wedge fields are very complex, but we're only using one point, a single point, to account for the wedge factor. But the wedge does change a scatter environment in 2D, but we're putting all that in one point. So that's why for wedge fields, you should expect, like up to 5%. If the shaping is minimal, so think of 4-field box technique, and you're blocking just the corner, so that's minimal shaping, then I could expect 3% is considered good enough of agreement that can say, go ahead with treatment. If there is substantial, you're doing the inverted Y or the hockey stick for, for the lymphoma treatment, Hodgkin's lymphoma, non-Hodgkin's lymphoma, those are very complex treatments, field shaping, then you should expect like around to 4%. So we do all this. So now, if your discrepancy between what you calculated versus what the TPS calculated is within 5%, I would say generally that is good agreement and you can go ahead. However, someone might say, well, what about whole brain? Brain is tissue. We should expect better agreement, 2%. What about breast? I mean, definitely breast is just literally like tissue, water. There's no bone in breast. So we should expect also good agreement, right? Well, we'll come to those examples later. Now, if we're talking about heterogeneity correction, so you are doing the plan in the TPS using heterogeneity correction, which I recommend. Okay, so don't turn off heterogeneity corrections in your TPS. Then what we're looking here, if I'm using the same patient geometry, I should expect up to 5%. But in manual MU calculation, I can only use assumption of a cube phantom. So how much should I expect? And that's a big question. That is missing from the report. And people need to ask, why is that missing from the report? Patient is heterogeneous. I'm turning on heterogeneity correction, the TPS. I get an MU value. Now I'm doing pen and paper or Excel sheet. And so the assumption is that this is the water phantom, everything water. What should I expect in terms of deviation? And here's the answer. I have two examples, brain and breast. I know we're beyond the 1 hour, but we're getting there. So this is 20 by 20 field size. This is your regular whole brain, German helmet, etc. About 20% blocked. You're prescribing to isocenter, exactly midline. Most of the brain is normal tissue. Your prescription is inside the brain, so far away from bone. So it's a water equivalency, is good assumption. Straightforward plan. I expect high agreement. But when you do the MU calculation with pen and pencil, or pen and paper, or with Excel, you're like, I have a 7% difference. What's going on? Well, here's the thing. What about all this air over here? When you put in the planning system, when you put in, or in your manual calculation, when I put in field size 20 by 20, and you're looking at the PDD for 20 by 20, remember, how did you measure your PDD? You measure 20 by 20, all of it in water. But in fact, we have air here. Air does not contribute to dose. Air does not contribute to scatter. So not all of your field size is generating scatter, is generating dose. So then what can I do? Well, first order of approximation, you can approximate how much air you have, and you would go ahead and assume that to be part of the block. Assume, again, right? We have to assume for manual calculation. Air does not contribute to scatter for the purpose of calculating those here at isocenter. So for all practical reasons, as if it is blocked. So now my field size has shrunk, it has decreased. Decreased field size, the monitor unit will change accordingly. So you do that, you estimate how much air is there, you assume that to be block, and you recalculate your field size, and you're still within 1 to 3%. I would say 1% is perfect. 3% is also good, but why are we still not getting exactly 100% like the TPS? Well, remember, your assumption, it's a flat water surface, a cube. The head is not a cube, it's an egg or a watermelon, depending on what you like. I like both. And so the planning system knows that the shape is, here in the beam eye view, you're seeing the maximum, right? That this is the maximum shape. You're seeing this projection. But as you go sideways, the thickness is less. It's different. So again, we have less scatter. Planning system knows that. You do not know that. Similar to breast. And by the way, breast, when I was doing manual MU calculation, if I got anything close to 8% in breast MU difference, I would be happy. You would probably find it's a little bit more. And for two reasons. Well, first of all, we have the issue of air, right? We have the air flash, 2 cm of air. That is not contributing much dose to here. So if I put in my MU calculation, this entire field size, remember in PDD, when you measured it in your water phantom, the entire field size was in water. But now I have a big chunk of it, maybe 30%, or a little bit more in air. So that's by itself will give you differences in a monitor unit. So we're going to do the same thing, right? We're going to assume this to be blocked area, and then redo our calculation. Again, this is for first order assumption or approximation. The other thing is breast, similar to brain, it has different shape. It's thicker in one side, thinner in other sides. And also, unlike brain, it is also different, thinner superior and thicker inferior. So not only the shape is, it's like an egg shaped in the middle, but also up and down, it's also different. A very complex shape. The planning system knows this. You do not know that. And if you're doing chest wall calculation, that's even more fun. Doing lung heterogeneity in the tissue, in the path of the beam, is the reason you will see discrepancies. And you will have to deal with two factors, the physical depth and the effective depth. I will not go into a lot. I know we're, the time is ticking here, but this is a lot of technical stuff that we need to keep in mind. So this is an example of a third-party software that we have been using until recently. And you can see it's taking all the information that you would take if you're doing manual calculation. And what we're treating here, we're treating supraclavicular fields. So this is breast treatment with supraclav, right anterior oblique, and right posterior oblique. And you see that Even this is like a software we bought, it's still using kind of an Excel type calculation. You know, we have the columns, then you have rows with information. So this is SSD at the calculation point. Remember, the calculation point is not necessarily at the ISO center. So you need to know the SSD at that calculation point. And then we have the off-axis ratio here. And what I want to show you is that the effective depth, you will use the effective depth for the PDD, but you will use the physical depth for the inverse square correction. And with all this complex, information, we are within 1%. And so we are happy, even though the supraclav area, right, it's decently flat. And in terms of heterogeneities, we have mostly tissue and, some bone, right? But the prescription is in tissue. And we still, with all this taken into account, we still have 1%, and that's considered good enough. That's actually perfect. So just to remember, we're not trying to get the same exact MUs. We're trying to prevent any gross errors that would lead to patient overdose. We're trying to find that computer bug. If it exists, we're trying to find that, wrong data point, if it exists, with all these different geometries that our patients have to go through. And what would you do if you cannot, you tried your best, you tried to think, oh, this is brain, let me take out the air, this is breast, let's take out the air, this is lung, let's do the effective, etc. And if you're still not within that 5%, or you still don't feel that something is wrong, well, that's when you start investigating what's wrong with the TPS. You can do, multiple things here. And we've done this, not frequently, but, a few times across the 25 years, where we could not explain the difference between the MU TPS and the MU that we have from the second check software or the way we calculate. So what you could do, you could take your plan and put it, copy it into the phantom, a water phantom. Every TPS, you can create a water phantom. So take the plan, copy it into the TPS, water phantom, and then basically you can measure. Say, okay, I'm taking this beam with the blocks, MLCs, whatever, taking the entire plan, putting it in a water phantom at this point, and now I can measure in my TPS. And if that is within the 2 to 3%, you can still go ahead. It just means that the actual plan was too complex for your simple monitor unit verification, that no matter how many times you try to, assume, presume, work with all these, assumptions, that is too complex for the MU to, to come up within the 5, 6, 7% that you want. If you do this, calculate in water, and you are within 2%, that's go ahead, that's good, go ahead and treat. If even within the water geometry, so I'm taking the plan, putting it in a water phantom, calculate and then measure. If I don't get 2%, then do not use that plan. It means that there's some bug, some wrong data point that is causing this MU discrepancy. So then you would be, let's replan, let's change parameters. Maybe the field, maybe the blocking is too much, that we end up, instead of having 3D CRT plan, we end up in the small beam dosimetry range. And your planning system is not commissioned for small beam dosimetry. So then you have to replan by changing parameters. I would say always start with reduced blocking. And maybe the point of your calculation is like at a bone lung interface. Don't do that. It's the worst case scenario. Your TPS is commissioned using water data. And if you're prescribing like at the interface of bone and lung, electrons are not in equilibrium. Photon attenuation is everywhere. Scatter is not homogeneous. So that, think about changing blocking, changing location of prescription, and redo the plan. So I've been talking about this. I don't need to repeat it. And then what other things you're looking for? Well, basically, you're trying to look for, and this is in the report. I don't need to, look at it in details. So I'll just go through it quickly here. You're looking at things that could fail. And if you're doing 3D CRT, right? If your calculation 3D CRT versus your calculation is 2D manual, so H donates things that have high failure or high error potential. Low is low potential for error. M is medium. So now you want to make sure that you look for things that could fail, because even in a 3D CRT, there would be hidden failures, especially if you're looking at the CT data set. If the planning system is commissioned with the CT in my radiation oncology department, but it's down, so I have to take the patient to the diagnostic department, but I don't have that commissioning table, I don't have the CT number versus density for that CT, that's an error, right? You're introducing calculation error. Maybe you're doing MR CT fusion. There's something wrong then with how you draw things. So always look for things that could fail. Have a checklist. And actually checklists were recognized as the one reason why errors are caught. Have a checklist and have in each clinic, everyone knows the clinic, say what is an acceptable uncertainty or deviation between TPS MU versus the manual MU. You're going to stick with 5%, maybe certain cases you take it to 8%, etc. Our therapists, they're the last line of defense. And they, of course, should have time out to verify that, this is the patient I'm treating. But also our therapists, they always catch up things. They always, catch documentation error. Maybe they say, hey, I cannot do this plan because the gantry will hit the couch, especially if you have couch angles. Therapists are very savvy. They're very intelligent because they have the room memorized in their head. Maybe a physicist who only deals with couch 0 cannot appreciate, a certain couch gantry angle that you have a collision. Therapists can also catch certain mistakes in prescription updates that did not go to the physicist. Certain planning systems, certain vendors are not very agile. A physician can change prescription, but it doesn't necessarily go to the planner, or is not communicated to the planner, so the therapist will catch that. So all in all, you want to make sure not only the physicists do their second checks, also you have a QA checklist for the therapists. Take-home message: in the era of 3D CRT, you require a lot of second checks. Definitely monitor unit calculation. You're taking CT-based data, you're taking complex geometry, and then you're prescribing to a point. That's the ICRU point. And then you're doing a lot of blocking, like Hodgkin's lymphoma. And then where would you put your prescription point? There's like a lot of tissue and bone. And of course, the lung is shielded. But that becomes very complex. How can your second check, whether it's manual or Excel or third party, how does it handle it? Inverted Y, how do you handle that? Where do you put there's extensive blocking. And so create your own tolerances for MU discrepancy and create your own checklists for that. And I'll have to say thank you so much for staying with me. I know we are half an hour over time, but there's a lot of information that I wanted to make sure that we convey especially for clinics who are going into 3D CRT, and the importance of doing per plan verification. And kind of the sooner you go into this mentality and habit of doing per plan verification, the easier it will be for IMRT transitioning. And any questions?
Thank you so much, Shada. So we are a little over time, but I think that as long as everyone's okay with it, we can take a couple questions. It's a lot of information for sure.
If people are willing to stay for an extra 10 minutes, maybe I can answer 2 or 3 questions. Other than that, then we can have the questions compiled. You send them to me, and then I can provide the answer.
Yes. And also, I'm going to post the RCC email in chat, so people can also email questions there after the session. So let's start with a question from Leroy. So when you have MUs that are in tolerance after your secondary check, what do you use? What MUs do you actually use for treatment?
I'm sorry, what is that? What's the question again?
You do your independent secondary calc, and your MUs are in agreement and in tolerance with the TPS. What MUs are you using for treatment?
Oh, the TPS MUs. Because the TPS MUs, they calculate for everything. They, the TPS knows the shape of the patient. They know the heterogeneity within the patient. And the TPS does a better job than us in getting the complex shape of the blocks of the beam, etc. So MU second check is just to verify that we don't have any mistakes. If they are within agreement, then you go ahead with treatment using the TPS information. I see someone asking for, say, is it possible to have the Excel sheet? The quick answer is no. The reason is the Excel sheet is done according to how we have taken the data. So the way that we have commissioned our linear accelerator, and whether it's, SSD, whether it's SAD, am I using PDD, am I using TMR? And it's also, how do we handle the heterogeneity? So when we had the Excel sheet, when I started working, the physics group, we came together and said, okay, how do you guys want to handle heterogeneity? How to use depth versus D effective? And what is the uncertainty we have for that? Also, remember I said textbook, the way to handle shielding, you separate phantom scatter from collimator scatter. In practice, we were able to find an easier solution that will be around 2 to 3% from, so simple geometry. Our solution was within 2 to 3% from, if we separate phantom scatter from collimator scatter from textbook solution. But we said, okay, you know what, for us, this is good enough. And now what we're going to do for these cases, we're going to add like the 2 to 3% on top of the 5%. So the way you build your Excel sheet should reflect your clinical, like you have to sit together as a team and say, this is how we're going to handle blocking, this is how we're going to handle lung treatment, this is how we're going to handle breast and brain. So it's better that you build your own, because that should be consensus to your own physics team.
Great, thank
So
you.
the answer, go ahead.
There's a couple other questions for second check software and things like that. I'll ask RCC just because I don't want to make recommendations on their behalf, and they might follow up via email with some options if they're able to make those recommendations, just for everybody here. And then I have one more question that came a lot earlier, and it basically boils down to, do all centers need to use the same calibration conditions and 1 centigrade per MU calibration? And if not, how does that go into the equations, or how do we use these different scenarios for our machine calibration?
Also good question. So centers do not need to have the same reference geometry. I have worked in centers that calibrate their LINAC, with SSD, so 100 cm SSD, Dmax, then by 10 field size, of course, always open beam. I've also worked in centers, or, actually went and trained others in centers where their LINAC is calibrated SAD. So the LINAC is SSD 90, depth of 10 cm. So that's 100 cm isocenter, right? And then they used TPR instead of PDD. The equation, so remember your K, your 1 centigrade per monitor unit. You want to make sure that you know exactly how you get the 1 centigrade to monitor unit, and then you do whatever is needed to correct back to it. The options you have are PDD, TMR, or TPR, tissue maximum ratio or tissue phantom ratio, or of course the percentage depth dose. And then the field size correction is the same. It's dose for this field divided by the dose to that field. But the measurement is your reference geometry. So if your LINAC is calibrated at Dmax, then you put the ion chamber at Dmax and you start changing the field size and you take the ratio. If your LINAC is calibrated at depth, then you put the chamber at depth, you change the field size, and basically you're trying to capture the differences in the output at the reference geometry for different scenarios. The 1 centigrade per monitor unit sometimes could be 0.99. In some centers in the US, especially if they are part of clinical trials, they are requested to report the dose not in water, but in tissue. And the the mass energy absorption coefficient ratio between tissue and water is 0.99. Now we say, water equals tissue, etc. This is good enough, right? And if you say, I'm going to calibrate 1 centigrade per monitor unit, this is what the majority of people do. But if you see centers calibrating 0.99 centigrade per monitor unit, it means that they are participating in a clinical trial that requires them to report dose to water. Dose to tissue. So 1 centigrade is good. Use that. 0.99, you'll be reporting dose to tissue instead of dose to water. And you have to be very careful now how you commission your planning system. Be safe. You measure in water. So report dose to water. That would be 1 centigrade per monitor unit. How the equation changes, that requires like a kind of a separate series of lectures on how to build the monitor unit equation depending on different scenarios. Just keep in mind, we need to know where the LINAC was calibrated, and everything is correcting to take you back to the calibration geometry.
That's great. Thank you. I think in the interest of time, we'll wrap up for today.